Apologise to everyone, you're going to get another dose of PNG, but I guess the angle of my talk today is to sort of talk you through the process of one of those dream analytical research pipelines that we sort of aspire to do, and one of the drugs that we have focused on and taken through that pipeline. So I'll be talking today about investigating antimalarial pharmacology in paediatric malaria in Papua New Guinea. So just as a little bit of an introduction, I guess, as Lawrence has said, in Madang we have both Plasmodium falciparum and Plasmodium vivax, both highly endemic. We did have some global fund money come through in 2010, and that allowed the distribution of long-lasting insecticide-treated bed nets, which was supposed to go to every single home within the province, in fact the country. And this was highly successful. In fact, they reported to 92% of homes actually received a bed net. And because of this, we saw a reduction in the prevalence of falciparum malaria down to less than 12%, which, you know, really is a significant success story in a setting like this. However, of course, there's always issues. You can distribute the bed nets, but that doesn't necessarily mean that people are going to want to sleep underneath them. So we've got a highly humid tropical environment. No wind is allowed to come through these bed nets, so people actually decided that it wasn't in their best interest to sleep underneath them. But we still did see the reduction in malaria, so again, a success story. However, we're now in 2017. Most of these bed nets are in very poor condition or worthless, in fact, and there's not yet any more funding for redistribution. So when I was up in PNG last week and talking to some of my colleagues at the PNG IMR, they were suggesting that their recent prevalence surveys were suggesting that falciparum malaria was back above 30% prevalence in Madang province. So again, we're seeing this re-emergence, and that was also reflected by the number of clinical cases that we were seeing presenting to our clinics. So as Lauren said, artemethyl lumefantrine, known as MALA-1 in PNG, is the first-line treatment for uncomplicated malaria, and they now like to do their diagnostics by RDT, which of course is a significant improvement in this kind of setting, because obviously training microscopists in order to diagnose from blood film is really quite difficult. But then we enter problems again. There's a national shortage of both MALA-1 and RDTs at the moment, and not enough money to purchase any more, which means we're actually finding that there's a lot of health centres that don't have access to both diagnosis or treatments, and they're reverting back to old-line therapies such as chloroquine. So again, one of these other challenges that we face sort of doing these kind of research studies in remote and endemic settings where there is not a lot of funding. So we focus most of our research out in Madang province in a little community centre called Acknowledgements, which is about 25 kilometres drive north of Madang township, also known as SEC. And a research collaboration was formed by Tim Davis with the PNG IMR in 2003, and since then we've been running pharmacological studies through this clinic in collaboration with the IMR. So at present, our team out there, we have a PNG clinician, we've got 2 nursing officers, community health workers, we've got 2 scientific officers, so one who's based in the laboratory at the main office who does all the molecular parasitology, and then we've got another one based out at the research clinic who does all the laboratory management and processing of samples. We have a study microscopist, and then of course, perhaps one of our most valuable assets that we have in the team are 2 Toyota Land Cruisers with drivers, and that enables us to follow up all of our patients, which is perhaps one of the major challenges in doing field-based studies, is actually retaining participants. And as I was discussing with Jason last night, I think one sort of statistic we're very proud of is we have about a 96% success rate of follow-up through to day 42 in our studies. And that's just because our drivers are well known in the community and they go down and that they find those children who are part of our research. So full kudos to them. And I guess in this red area, it's just sort of showing our recruitment area that we have in the Alexisarfan community. So it extends for a good 25 to 30 kilometres either side and then to the foothills. There's one major central road and then you have to go off-road into the jungle. Often you have to walk to find people, but we find people. So during this time from 2003 onwards, we've completed 9 antimalarial pharmacology clinical trials, and all of these have been done through funding by NHMRC, the Malaria and Pregnancy Consortium, and Bill and Melinda Gates Foundation and AusAid. So we're very thankful for all the financial support we get. And that little photograph at the bottom is actually the Alexis Arfin Health Centre. It consists of, on the left-hand side, we have our inpatient centre, we've got a labour ward, an antenatal clinic, and the rotunda is actually where everyone presents when they come sick. So you get given a number, you sit there, when your number's called, you go up, you're seen by a nurse, you get given your treatment, and off you go home, unless you're sick enough to be put into the hospital. So again, here's this idealised pipeline that we have for our research. Try and identify a need for an area where there might be some lacking data or a requirement for an optimised therapy, developing that assay, then putting that into clinical studies, pharmacokinetic studies with high intensive sampling procedures, get some modelling done, and then develop that and put it into a clinical trial to see if we can get an optimised treatment. And of course, again, none of this is possible without all of the collaborative partners that we work with, which extends to a number of international as well as domestic research institutes, and of course, funding partners. So for all our pharmacokinetic dynamic studies, we really rely on a standardised study design. So we're looking at a multifaceted clinical study where we evaluate the safety, tolerability, efficacy and pharmacokinetics of the antimalarial compounds that we're investigating. We then try to optimise these for treatment regimens that are applicable within PNG population for that paediatric group who have the uncomplicated malaria. We have a standardised follow-up schedule, so we will recruit, which is known as the baseline or day 0. We then do standardised reports at 4 hours, 12 hours, and then on day 1, 2, 3, 4, 7, 14, 28 and 42. For pregnancy studies, we also follow them through to the time of delivery. Most of the time points after day 42 will just be wellness checks to make sure that the pregnancy is going well. And then at the time of delivery, we get delivery samples and then collect breast milk samples for a month afterwards to look at drug transfer through those. For our pharmacokinetic studies, they're most often intensive sampling protocols. And because of that, we often need to admit the patient to the clinic, at least for the first night, to allow us to collect frequent samples during that 24 hours. And then the later time points we follow up in the village, like the photo at the bottom demonstrates there. So we're able to just find an area within the home where we can do our questionnaires and bleeding time points. So let's go through this progression, looking at one drug that we've focused on called ARCO. So first of all, identifying a clinical need. Well, as Lauren's went through, one of the first treatment clinical trials that were done, which we know as the standard treatment trial, was comparing 4 different new artemisinin combination therapies for replacement of chloroquine SP as the standard treatment in PNG because of the high rates of chloroquine resistance. They were looking at children from 6 months to 5 years with both or either falciparum or Vivax malaria. So from these, as Lauren's highlighted, we saw artemether-lumefantrine and dihydroartemisinin piperacin were highly efficacious for falciparum malaria treatment, but for Vivax, it was quite lacking. And now Vivax is a very prevalent species in the Madang area. While it's referred to as a benign malaria, it does have morbidity issues correlated with the long-term and chronic nature of the infection. So even though dihydroartemisinin piperacin had the highest cure rate, I guess, for Vivax malaria at 66.9%, AL was still selected as the national standard treatment as a result of these studies because of that sort of severity of falciparum malaria and the high rates. But obviously we have a requirement here to try and look for other drugs that perhaps may be more efficacious for the treatment of both species. And at the same time as this study was being written up, we heard of this relatively new drug called ARCO, which is a combination of artemisinin and nafthacin. And it was available commercially within the pharmacies in country in Papua New Guinea, but it is not what we call a quality assured artemisinin combination therapy. So the World Health Organization do not endorse this drug. And that is primarily because the manufacturer recommends a single dose therapy for complete cure of uncomplicated malaria. And the WHO has a standardised 3-day treatment for ACT therapy of malaria. So obviously this means that it's not going to qualify for the regulatory assessments that are required through WHO. However, it's still potentially a really valuable drug, and as such, because there was very limited data available both in adult and paediatric cases, we decided to investigate it further. So we decided to do a pharmacokinetic dose ranging study. But first of all, of course, we need our assay development. So our assay, I guess the basis of what we do is Dr. Madhu Page-Sharp, who's our research fellow based at Curtin University and who is responsible for the development, validation, optimisation of all our analytical methods. And then she also goes and runs all the clinical samples that we send from Papua New Guinea as well. And she has developed HPLC and LCMS assays for all of our studied antimalarial compounds, and this has been done for plasma, whole blood. Now we're getting into the dry blood spots, breast milk, and also CSF. So obviously we've got a range of capacity for a whole different lot of mediums for measurements of the antimalarial compounds. During this sort of progression, I guess, of studies we've done in PNG, we've also seen an evolution of our assay capability within our research group. And that sort of moved from using HPLC and measuring of drugs, where obviously we need large volumes of samples, right through the single quad, triple quad Shimadzu systems, and then of course our holy grail and our dream is to upgrade that. I say 12 months, it's probably not particularly realistic, but when funding is available, to the 8060 LCMS system. Okay, so first of all, we wanted to do dose-ranging studies of ARCO in our children who had uncomplicated malaria. So we're going to look at the safety, efficacy, tolerability, and pharmacokinetics. We chose children 5 to 10 years because obviously we don't want to be doing these kind of studies, especially with frequent sampling in very young infants. So 5 to 10 years is seen as an acceptable and ethically approved group for doing this sort of work. And as a result, we were able to publish this nice pigeon pair of papers, one focusing on, obviously, safety tolerability, and then the other on pharmacokinetics. So basically what we had here is we 3 different groups in terms of our study. Group 1 was run independently and was just a single placement into the treatment. And then later on, a year or 2 later, we did a randomisation between Group 2 and Group 3. So for Group 1, it was just a single dose of the treatment. At that time, the manufacturer recommended 2 to 4 tablets based on weight, and it was given with water. When we then went through to our Group 2 and 3, by that time, the manufacturer had actually changed their dosing recommendations on a weight basis. So it went up to a 3 to 6 whole tablet dose administration, and we did one group that was given a single dose with full cream milk in order to see whether the administration with fat would increase bioavailability and therefore make it more efficacious as a single dose. And then we also looked at 2 doses given with water, in which state our children were fasted. So then in order to look at the safety, we do a whole lot of measurements at those stipulated time points, which are quite generic across the studies. We do microscopy and PCR in order to look at the treatment efficacy of our groups, a questionnaire to assess tolerability, and then of course our pharmacokinetic time points. So for these studies, the children were admitted for the first 3 days into the health centre so we could observe them for safety purposes, and then all the samples were taken from an indwelling cannula to prevent sort of infection sites with frequent venipuncture. So I guess this sort of summarises, and basically we found that single dose was not particularly good for efficacy. We had a 53% recurrent infection in our dose 1 group with the water, and one of those was actually a recrudescent infection. So we didn't even get rid of the parasites, and so they were able to regenerate. Group 2 and 3 were slightly more promising. However, again, it's demonstrating that this clearly cannot be used as a single dose therapy within this setting. All our safety checks and tolerability, however, were quite satisfactory. In terms of the pharmacokinetics, the naphthalene was assayed by HPLC and the artemisinin by the single quad. So we were able to determine for naphthalene that it was very promptly absorbed, had a mean elimination half-life of 524 hours, so it was quite long. We did see a modest increase in bioavailability with fat, however, it wasn't particularly significant enough in order for us to recommend it as a treatment that had to be given with fat, like artemethyl lumefantrine. And we saw that the bioavailability of naphthalene was improved after a second dose, which was associated with a better clinical outcome. So all promising signs in order to move it towards that WHO stipulation of a 3-dose therapy. So then we go on to the pharmacokinetic modelling simulations, and this is all done by Dr. Sam Salmon, who is our expert modeller in the group. I'm not allowed to make any jokes about that. But for these studies, he used nonlinear mixed effects modelling using non-MEM, and his simulations suggested that the 3 daily dose regimen would be safe. We would get much closer, obviously, to our 60 milligram per kilogram artemisinin dose that's required as far as a recommended treatment, and that we would have therapeutically effective blood naphthalene levels for more than 3 weeks. So this is really showing quite a nice duration of prophylaxis in a way after treatment, which would allow hematological recovery. So again, promising signs. So then we developed this into a clinical trial, and this was called the Standard Treatment Trial number 2. And here we did a 3-year open-labelled randomised study where we randomised children to either receive the national standard treatment of artemethyl lumefantrine or into the artemisinin naphthalene group. And we again compared them for all safety, efficacy, etc. This paper was published in PLOS Med and was a really nice summary of everything we were able to achieve from that. So through here, we screened over 2,500 children looking for those who would be eligible in terms of our rather strict eligibility criteria. And this was done both out in the field, so going and doing community health sessions out in villages, but then also those who were actually coming to the health centre when they were sick. From those, we were able to enrol 267 who were actually put into the trial and then randomised. For the first 188 children, they underwent a very strict safety assessment, and this was just to make sure that the 3 doses of artemisinin and naphthalene were actually a safe therapy to use in comparison to the artemethyl lumefantrine. We looked at ECGs, biochemistry, haematology, etc. So from this, we were able to determine that we had a nice variation of both falciparum and vivax malaria. Some people did have mixed infections, and this was diagnosed by both microscopy, RDT, and PCR. We did have some excluded, which were later done because we found that they actually didn't have malaria or they had levels that were too low density in order to be included into the study. But then the rest were actually randomised into our treatment arms and received either the ARCO or the COARTEM treatment. And then we followed these up at our standardised time points out to day 42, looking at questionnaires, clinical examinations, etc. through there. So what did we find? Well, basically we found that in terms of safety, both drugs had a modest increase in QTC time after administration, as we would expect with these classes of drugs, but it was normalised again by day 7. So no levels really exceeded that, which was seen as a clinical cardiotoxicity, so we were quite happy. Haemoglobin concentrations, whilst they initially dipped, as we would expect by a clearance of malaria infection, we saw haematological recovery over the 42-day period, which was fantastic. For treatment efficacy, we did see a difference between the two treatment arms. So for falciparum and malaria, both treatments were seen to be perfectly acceptable within the WHO 95% ACPR. But for Vivax, we actually saw some recrudescent cases in our artemethyl lumefantrine arm, while no cases were seen after artemisinin and nafthacin after the 3 doses. So we had 100% ACPR at day 42 for AN, which was incredibly promising given the fact that we are actually looking for a drug that is effective to treat both species. We also looked at gametocyte counts. Now, gametocytes are the sexual forms of parasite that are taken up into mosquitoes and are responsible for the transmission of infection. So obviously these are important to measure in order to see whether or not, I mean, if you're not killing gametocytes, you're still allowing malaria to be transmitted through the population. And here we actually saw that artemisinin and nafthacin was particularly good with the Vivax gametocytes as well. So again, another promising factor. So from this, we were able to conclude that both treatments were safe, well tolerated and highly efficacious for both PF and PV, that artemisinin and nafthacin was non-inferior for safety, non-inferior for tolerability, non-inferior for treatment efficacy for PF, but of course superior in order for treatment of Plasmodium vivax. So the advantages that we see for the artemisinin and nafthacin therapy as a 3-dose regimen is that we only give it once a day for 3 days and it can be given with water. Now this is very good for compliance because obviously artemethyl lumefantrine is given twice a day and should be taken with fat in order to increase the bioavailability and treatment efficacy. So having just a 3-day single dose with water means that we're likely to have better compliance. Obviously as well, the superiority for Vivax is perfect for PNG. The disadvantages, of course, is that this treatment isn't endorsed by the WHO, so it's not something that we can actually just recommend for widespread use through the country. But hopefully over time and more research, we might get there. So I guess just to sort of finish up, I wanted to quickly outline some of the challenges that I have faced while working with the team in PNG doing these kind of studies. Firstly, we do have the patient follow-up. Now, whilst we do have really good follow-up success, it's a lot of hard work to maintain this. We have a large recruitment follow-up area, accessibility. So as I said, we often have to park the car and walk in to see the kids. And of course, once they get well again, after that 24 hours of treatment, the kids are off playing, they're in the garden. So you really do have to make sure that you are there at a suitable time to get them. The positive thing with this is our drivers are well known. They're very good at telling the mother, we'll be here at this time on this day. We give them a little printed out calendar which is highlighted so that they know when we're coming, and quite often they'll actually walk out and stand by the main road for us. So that does help. Then of course we've got sample processing and storage issues. Unstable electricity. Out at Alexisarfen we have a blackout 1 to 3 times a day. Now this is a problem obviously if we're taking venous samples and we need to centrifuge them to separate out the plasma. It would be great to say that the blackout happened when we didn't need to use it, but of course it always happens directly when you load your centrifuge up to spin. So what we've had to do is get a little generator that can power just the one machine. So when we have times of blackout, we're able to do that. We also have a fantastic relationship with the health centre. So for periods of long blackout, if they exceed sort of that 4 to 6 hours, the health centre will often put on the generator for us and run it if we buy them diesel to run it. So it's sort of a give-take relationship. Microscopy for diagnosis, obviously. You can't do microscopy if you don't have electricity. And then, of course, we've got storage issues. If you've got your freezers with all your samples out there, having the blackouts constantly is a major issue. So what we have to do is each day we have to drive all of our samples up to the main laboratory, which is about a 40-minute drive away, in order to keep them at a more stable supply of power. And then, of course, you've got something like cultural sensitivities. So collecting frequent large volume blood samples in PNG is often seen as taboo. In our area, black magic and sorcery is still practiced by some people. So by you actually collecting blood samples, people don't understand what you want to do with that blood. And there is that fear of black magic and that you actually may cause some harm to their child just by taking that essence of them. So establishing a really strong, healthy relationship with the community, keeping them engaged and educated about what we do, is perhaps one of the fundamental things we need to set up as a foundation for all our studies, so that people are not scared to participate. And I guess they get the benefit as well. If you enrol in one of the studies, that family effectively is looked after for 42 days, because if one of the other siblings gets sick, they get antimicrobial treatments as required. So there's sort of, again, that give-take relationship. And then, of course, many of the evaluations we want to do, like an ECG, it's really scary for a kid to have this piece of all these little tabs put on their chest and noises and laying still, and, you know, the mothers are like, pretend you're dead, and it's, you know, it is quite a scary procedure. So, of course, that's something we really had to come to terms with in terms of getting our baseline values, because, of course, everyone's stressed. Their heart rates have gone up, and we're getting QTCs that are well over the normal baseline level. So again, it's just about trying to be pragmatic and work out how to set up a system so everyone's relaxed and you can get reliable data. So where to from here? Well, we have 2 new NHMRC funded trials, which were supposed to start at the beginning of this year, but they are going through the process of ethics at the moment. So hopefully recruitment will start at the beginning of next year. One of those, we're looking at pharmacology of ACTs in postpartum women and their infants. And then the other, which Lawrence referred to previously, is looking at our primaquine regimens. So in terms of our assay capabilities, we're continuing to evolve. So we're putting sparse sampling protocols into these trials, and over 85% of our sample collection will be microsamples through DBS. And Madhu is also in the process of getting some really nice, robust assays for artemisinin and derivatives, which is yet to really be established anywhere in the malaria community. So we're quite excited about that. So finally, it would be remiss of me not to acknowledge all of those who are involved. And of course, there's many names. I can't put everyone on here. But the integral part of everything we do is our drug study team up at Alexis Artham Clinic, all our nurses and doctors, the drivers, everyone who's involved in the collection of this really valuable information, which obviously I can't be part of when I'm here in Australia, so they do a fantastic job. We've got our colleagues at PNG IMR, of course our malaria research group, and we've also got very strong relationships with WeHi and the University of Melbourne with some collaborators. And of course NHMRC, who have been more than generous for all of our studies in funding and my fellowship. So thank you so much for listening. I hope you've learned a bit about PNG, but hopefully not too much.